Good evening, everyone. Thank you very much for joining us and welcome to our webinar on modern techniques in knee replacement surgery. I'm Katie, one of the members of the marketing team, and I'm delighted to be joined by Mr. Christopher Buckle, one of our consultant orthopaedic surgeons here at the Horder Centre. Mr. Buckle's clinical expertise encompasses the management of degenerative hip and knee conditions using modern and minimally invasive techniques. His clinical expertise also involves the management of problematic, painful, and failing hip knee replacements. Before I hand over to Mr. Buckle and his presentation, just want to remind you that this is a live recorded event and the recording will be emailed to you tomorrow. Please be aware that we won't be able to respond to hands directly, but do drop any questions that you have into the Q&A box and we'll ensure to address them during our segment later in the webinar. Once again, thank you all very much for joining us and please welcome Mr. Christopher Buckle.
Thank you, Katie. Good evening, everybody, and thank you very much for spending your evenings to come and listen to this talk this evening. As Katie said, please feel free to put questions and comments in the question box and we'll try and address those at the end. I think some of you have sent in some questions before the meeting and hopefully I've been able to build in some of that information to the presentation. And so, as Katie said, the topic tonight is knee replacement surgery and in particular focus around what is new and modern in terms of technical advances in knee replacement surgery. And so the plan for this evening is to just give you a brief understanding of where we are, where did knee replacements start, what's happened up until this point. An idea of where we've come from is helpful to understand where we are going to. And then importantly, talking about the process of surgery. So what's involved in the preoperative preparation to try and improve outcomes around surgery, the surgical techniques, importantly, and implants that are used. And those implants, a particularly relevant conversation for lots of people, can be the use of both partial and total joint replacements. Importantly, here at the Horder Centre, we do utilise robotic surgery in certain circumstances and giving you an understanding of what this involves and what the expectations and potential advantages of this are. Again, giving you an understanding of the recovery processes and what you can expect from knee replacements, and again, answering your questions around those. And there'll be a brief discussion around alternative treatments, although that can potentially be an entire conversation on its own, so that will be a brief discussion. So, as I said, where have we come from? So knee replacements are still relatively new. They are really only something that came into mainstream use in around the sort of 1960s. There were attempts to try and replace joints before that, and most of those involved using ivory, as that was perceived as a reasonable representation of what bone is. But the first major knee replacements came around just around the 1960s, and they were a sort of hinged prosthesis. And lots of the major advances came in the 1970s, where the design of what we perceive as a modern knee replacement was founded. And then over the course of time, the design of knee replacements hasn't fundamentally changed, but some of the technologies we use to try and improve the precision with which we place the implants has changed. And so you can see the timeline here. Most of the activity sort of is around the 70s. And then the advent of computer-assisted navigation, which is essentially a precursor to the use of robotics, occurred in the 90s. So this is what the original knee replacement looked like. It is essentially a hinge, a bit like the hinge on a door that you would see. It operates in two planes. You're able to bend it and you're able to straighten it. It does no more than that. And outwardly, that may seem like a very reasonable thing to do to your knee. Your knee very much looks like it bends and straightens in one direction. But unfortunately, things are much more complicated than that. And this knee replacement, unfortunately, was prone to really quite high rates of failure because it failed to address some of the fundamental things about your normal anatomy. It failed to address how your knee's normally aligned. It failed to address the important ligamentous structures, so those soft tissues that control the movement of your knee. And because of these failures to address these problems, the knee rapidly failed and became loose. And so the major advances we talked about that occurred in the 70s were happening across the Atlantic and in London, and they were happening in parallel, and ultimately both came to very similar sorts of conclusions. And these are some pictures of those knee replacements that were first designed. On the left-hand side was the one that was designed in London at UCLH, and the two on the right-hand side were the knee replacements that were designed in New York, the Hospital for Special Surgery. And actually those two knee replacements on the right are still the precursors to the modern knee replacements that we use now. And in fact, the one on the very right, there are still some of them put in within recent history. And the key different factors to that first knee replacement we saw are they are two completely separate components. They are not tied together like a hinge. They are freely mobile from each other, and therefore, importantly, pay respect to some of the soft tissues around the knee, particularly the ligamentous structures, and so therefore offered the advantages of giving a more normal and naturally functioning knee. Importantly, they are not replacing the whole of the bone. If you look in the profile from the side, the knee replacement's essentially being the joint and the bone is essentially being resurfaced rather than being completely resected. And so these prove to be the modern technique of how we use knee replacements. And when we look at today's knee replacements, they are actually very similar in their design. So these are two knee replacements we use here at the Horder Centre. The one on the left is something called a Vanguard knee replacement, which has been in manufacture for about 18 to 20 years now. And the one on the right is the later generation of this knee replacement, and that's been used for approximately 10 years now. And the key things about these, they maintain that respect for the soft tissue structures around the knee, providing more natural and normal kinematics, i.e. the normal movement that you would expect of a knee replacement, a normal knee. And they offer the advantages of having the ability to personalize the implant size to the patient, to personalize the size of the bearing surface, so the small plastic piece of material that sits between the two metal implants, to again recreate normal anatomy. Some of the subtle things you might see that have changed between these two knee replacements are the ability to change that bearing in size, but also the material it's made of. It's made of a harder wearing plastic surface, which potentially offers longer term solutions to the knee replacement wearing out. And so that is where we are in terms of designs of knee replacements. And I'd say the vast majority of those advances were made quite early on, and we've had subtle incremental change in their design over time. But the mainstay of treatment is actually the advantages have been how we implant the knee and some of the techniques and philosophies we use to try and recreate your normal anatomy. And we'll go into that a little bit more going forwards. And so what we'll do is just take a step backwards and have a think about why you might end up having a conversation around knee replacements in the first place. And so knee replacements, much like hip replacements, are an operation that is fundamentally about quality of life. They're about improving your pain, improving your mobility, improving your day-to-day function, and therefore the resultant quality of life. And the reasons for your knee to have problems in general relate to osteoarthritis in the vast majority of people. So osteoarthritis is a wear and tear degenerative process where the normal lining of the joint surfaces, the cartilage that sits on the surface, is eroded and worn away. And if you come to clinics, what you often see are the x-rays that you can see on the screen here. We've got a comparator on the in blue here where it demonstrates a normal knee, where an x-ray shows you the bones, but what it doesn't show you is cartilage. And so the cartilage appears as a gap between the bones, and the bones are held apart with a normal space between them. But as you develop arthritis, that cartilage wears away. And you can see that here on the red here, where the joint space, the room between the bones, has completely disappeared, and you are now left with bone rubbing on bone. And often that can be perceived as a painful, crunching, grinding sensation within the knee, as those once smooth surfaces are roughened and irregular and rubbing against each other. And what you might even notice is it's worn out more on one side than the other. And that does happen in lots of patients. Patients are not all built with legs in a straight line. Some are slightly bowed in one direction or the other, and that can predispose you to wearing your knee out on one aspect of the joint rather than another aspect of the joint. And if you look, the overall alignment on the blue picture is a straight line, whereas the red one is a slightly curved picture because you've lost that room in the joint on that side. And that is over 90% of the people who come in with problems with their knees relate to osteoarthritis. There are some other conditions that can affect patients, and those typically are, again, other forms of arthritis, but that are fundamentally different. So rheumatoid arthritis is a condition of joint inflammation that not just affects your knees, can affect lots of other small joints around the body. The treatments of that have been revolutionized over the course of the last few years with the advent of medical treatments for rheumatoid arthritis, and that has almost got rid of the need to do joint replacements for rheumatoid arthritis. Unfortunately, that is not quite the same for osteoarthritis. We haven't got medical treatments that are able to eliminate the progression of osteoarthritis, and so joint replacements are still a very, very relevant conversation for patients with that problem. And then other sorts of problems, so previous injuries, whether that be broken bones or injuries to ligaments or tendons, can predispose the joint to wearing out sooner rather than later. And so that's what I mean by post-traumatic arthritis. And so it's important to, before we go through a knee replacement talk, is really to think about the alternatives. And generally, before you come anywhere near seeing a surgeon, most patients will have a conversation with their GP about their symptoms. GPs are really capable of, guiding you through the initial management, and more often than not will have referred you to a physiotherapist. And that's a fundamental part of the management of arthritis, is really about maintaining your overall health and your muscular health and movement around that joint. And in order to be able to do that, the use of painkillers, so whether that be tablet form or topical, so medications that are rubbed on the skin, that is the mainstay of treatment before you get into conversations around alternative treatments for the management of your arthritis. And lots of things that people have heard about are the use of injections. And injections, unfortunately, are not something that we've got that can reverse the process of arthritis. They are there to try and improve the symptoms, i.e. improve the pain, allowing you to exercise and allowing you to get back to a normal quality of life. And the gold standard of these treatments has always been steroid injections. They are a powerful anti-inflammatory drug injected into the knee that can reduce the inflammation, but more importantly, reduce the pain caused by arthritis. They are short-lived. They tend to only have an action for a few months, and may need redoing over time, and so therefore may not be a long-term solution. But if they do provide you with relief, they can allow you to do the things that can provide lasting benefits, such as physiotherapy. I've written here there is alternative joint injections, and you may go do some reading, you may talk to lots of other people about different sorts of injections. The reason I've only put two here is because most of the evidence that we're starting to see around some of the other injections, such as hyaluronic acid, there's trade names for that, such as Synvisc, are actually starting to show they probably don't work as well as we thought. And most insurance companies have stopped funding hyaluronic acid injections, and certainly the NHS no longer funds hyaluronic acid injections. Arthrosamid is there, and that's actually a relatively new injection that functions not in a hugely dissimilar way to steroids, i.e. it reduces pain, but the intention is for pain to be reduced for a more prolonged period of time. And I'll talk about that again in a moment. Other things that can be considered to knee replacement can be around how we think about how your knee aligns. And that concept I mentioned earlier on about your knee can wear out in one part rather than the other, causing your leg to become more bowed. So what you can do is actually try and reduce some of the weight through that worn out bit of your knee, which if it's not bearing as much weight, can be less painful. And so very specific sorts of bracing can be used to effectively straighten the leg out, so to take the weight away from that worn out bit, providing you with symptomatic relief. Those braces are worn externally. That therefore can be a little bit cumbersome, does involve putting something on your leg all the time, and some people find it very beneficial in terms of their symptoms, but it's not a practical thing to wear. But again, is an alternative that one can consider before going through major joint replacement. And then finally on the slide here, I mentioned joint realignment surgery. So again, goes back to that concept of wearing out parts of the knee faster than other bits of the knee. And the idea that rather than doing it through an external brace, one can actually change the alignment of the bones within your knee. So to put it in sort of really simple terms, that involves breaking the bones, straightening them out to recreate that effect of the brace to offload it here. And those two pictures on the left-hand side of the screen there demonstrate a patient with an ever so subtly bowed leg, and the yellow line demonstrates where they bear their weight from their hip all the way down to their feet, and it just misses the knee. So most of the weight's going through the inside of the knee. But with a little procedure to realign the leg, and that's what that white plate there is, the weight is now borne through a healthy part of their knee and therefore can improve their symptoms. Those sorts of surgeries are generally reserved for patients under the age of 40, 45, but can be used in slightly older patients. And again, important counselling for patients to discuss the relative pros and cons of that. So I quickly go back to this arthrosamid. It's something the Horder Centre has started to offer. It's important to mention it. And what it does is this is a demonstration of essentially what patients can tell us in a quantitative way. We can ask questions of patients about how their symptoms are, and we can see how their symptoms change over time. And what this demonstrates is that the symptoms improve early on, which is what you would see with lots of things such as steroid injections. But more importantly, over the course of 2 and 3 years, those symptoms are potentially improved over a longer period of time. So if you've had conversations around the alternative treatment, potentially tried some of those treatments, and they haven't been effective or we've deemed them not to be appropriate, then we're looking at joint replacement surgery. And that's what this evening's conversation is about where we are with joint replacement surgery, what's involved, and your recovery from that. So before any major operation, it's important to prepare for it. And though the reason it's important to prepare for it is really all about reducing the risks of major surgery and therefore improving the outcomes of that surgery. And lots of this is really some common sense, and some of it is us intervening in a medical fashion. But the top of it is smoking and alcohol. That you speak to your GP, those will be fundamental things they'll be addressing and looking at every time they see you, because we know that if we reduce some of the burden of those diseases or those drugs on the body, that can improve your ability to go through an anaesthetic safely and reduce some of the risks around surgery. Regularly, we look at body mass index, and you may be aware of there are some thresholds to surgery related to body mass index. Body mass index is your height and your weight and a measurement of how those two things interact with each other. And the reason that gets talked about a lot is that the higher your body mass index, i.e. the higher your weight compared to how tall you are, the more likely you are to have complications and the more likely you are to have early failures of your knee or other joint replacements. And that picture on the right is essentially, if we break it down into how high somebody's body mass index are, the higher your body mass index is, the more likely you are to have complications and more likely you are to have joint failures over time. And so the reason that's mentioned in the preoperative phase is actually it's a modifiable risk factor. There are things that can be done about it. Nobody proposes it's an easy thing to do anything about, but with the right guidance, and there are now things that your GPs may prescribe to you to try and help reduce weight that can optimize your outcomes following major surgery. And before I mentioned exercise, that runs fundamentally throughout the treatment of joint arthritis, whether you have a non-surgical route or whether you end up with an operation. But ultimately, the stronger you are going into an operation, the more mobile your joints are, the better you are coming out of it. And importantly, the stronger your heart and lungs are going into it, the better you are coming out of it. Part of the process of preparing for the operation is to optimize pre-existing medical conditions. Now, most patients with all sorts of medical conditions can safely undergo an operation, provided they are optimized. So diabetes is a really common one that we see now, and there are quantitative measures that we use to try and understand how well your diabetes is managed. The reason for that is, again, the risks associated with poorly controlled diabetes particularly relate to wound healing issues and the risk of infection around surgery. You will undergo medical checks for your cardiovascular function, such as tracing of your heart, your blood pressure, your heart rate, and also your respiratory function, given the need to go through an anaesthetic. There are several other medical conditions that obviously are looked at. Chronic conditions such as Parkinson's may be relevant to people, and patients safely undergo surgery for Parkinson's, but importantly, maintaining their medical management of that disease process throughout. You'll undergo medication reviews, and the vast majority of medications, importantly, carry on throughout the surgery, and only ones that are relevant are stopped. That can include certain diabetic medications, certain heart failure medications, and importantly, the blood thinners. Interestingly, we don't stop all your blood thinners. If you're on aspirin, you can safely undergo an operation while still on aspirin, and that can still then help maintain the benefits that you're taking the aspirin for, i.e. your prevention of stroke is the most common reason you're having that. And the other things that we'll normally go through before you're having an operation is the importance of removing risk factors for infection. And there are an enormous number of things that we do to manage infection at the time of surgery. And the things that you will experience at home are the decolonization of bacteria. So the washes that we use to try and remove those bugs that sit on everybody's skin, to try and again remove some of the risks and optimize your recovery following surgery. Some other things to consider are how you'll recover from the operation. And the physiotherapist will go through with you some of these considerations. And importantly, there's very helpful information leaflets we've got on the website to talk about how you can plan your discharge and your expectations. Patients are always, more often than not, not always, discharged back to their own home in a safe fashion. And it's entirely reasonable to be back at home with some social support from somebody to pop in, make you cups of tea, look after the shopping. But some patients choose to go have some further rehab in a rehabilitation facility. But most of that rehab is actually done whilst you're in hospital, and then you're given the provision of information and the encouragement to do that independently at home. It's important to make sure that their home is safe and you've removed the risks of tripping hazards and things like that, because you will be using walking aids when you go home. But as I say, lots of this information is on the patient information leaflets provided to you prior to the time of surgery, and the physiotherapists run through this with you. So the process of operation is entirely dependent on not just the surgery, not just the surgical techniques, but those processes that are going on around you. And that's where huge advances have occurred over time. If we look back at the 1960s when these joint replacements were being done, patients were immobilized in bed for a week to 2 weeks to allow the soft tissues in the wound to heal, to help manage their pain before getting them up and moving around. And that process itself is a slow process. It slows your recovery. It reduces the level of function you have afterwards. And so now modern thoughts around joint replacements are how we can go about getting you up and out of bed as quickly as possible in a safe and comfortable and timely fashion. And lots of things go into that. So in terms of the process of the anaesthetic, that's where this process starts. And it may be a surprise to some people that you can have knee replacement or major joint replacement surgery whilst wide awake. And that is done by the use of a spinal anaesthetic. So a small needle that goes into the back, numbs you from the waist down, and that provides adequate analgesia and anaesthesia to undergo a joint replacement safely. That in itself is a bit of a scary thought for lots of people. And so more often than not, our anaesthetists are quite kind and drift you off to sleep. So you are anaesthetised with a spinal anaesthetic and sedated as well. And that offers the advantages of being able to very rapidly turn the sedation off, and you don't have some of the hangovers or the consequence of having lots of general anaesthetic, which can make some patients feel nauseous and sick afterwards. And the advantage of the spinal anaesthetic, it provides really good pain relief that can last for several hours into the evening after your operation, again allowing that rehabilitation process to start. In addition to those anaesthetics, we use lots of local anaesthetic both around the knee, physically put in at the time of surgery to numb the joint itself, and also into the nerves specifically supplying the knee. So in two manners, we block the nerves going towards the knee, and we also numb the tissues in the knee. And again, these provide good pain relief after the operation. So once the spinal anaesthetic is worn off and the muscles are all back awake, you can actually be up and moving around, still with some local anaesthetic working in there. But I'm sure it would be remiss of me to say that it's not a pain-free operation. There is pain after a knee replacement, and that is one of the challenges we try and address, and that is done through these anaesthetic techniques, but also through multimodal pain control. That is through both short-acting, strong opiate type pain relief, and also a layered approach to other pain relief on top of that. There are external things that can be done again to try and improve the pain, and that is the use of cooling or ice bandaging around the knee, which both helps reduce the swelling and the inflammation of the knee, but also can help reduce the pain. There are other subtle differences that you can do. So I've put tourniquet free here. So traditionally, when you do a knee replacement, a tourniquet is applied around the thigh, and that stops the blood going to the knee. And that's a helpful thing in terms of being able to do the operation. It means there is less blood, and therefore the operation can be done in a manner where you have a blood-free field. But that has quite significant consequence. If you cut the blood supply off to your leg for 45 minutes, that would be incredibly painful, and you wouldn't be able to tolerate that without an anaesthetic. And that has consequent effect after the operation. Once the blood supply returns to the leg, the tourniquet itself can be a really painful part of the procedure and does limit some of the pain. And so what we've actually found is doing knee replacement without a tourniquet involves very little in the way of bleeding, much like if you have a hip replacement, you don't have a tourniquet on, and offers the advantages of not having that pain associated with the tourniquet afterwards. Essentially, all of these things are about managing pain around a knee replacement, and we've done lots of things to improve that and help with pain relief afterwards to facilitate that early rehabilitation. And we use the term enhanced recovery, and that was sort of a term coined in the 90s, but it's essentially about not having a period of rest and recuperation. It's about being up, moving around, moving that joint, getting out of bed. And we know that's a good thing, both in terms of the functional outcomes of joint replacement surgery, but it also helps reduce lots of the risks associated with surgery. So the quicker you're moving around, you have lower risk of blood clots, you have lower risk of developing pressure sores, you have lower risk of developing breathing problems by being in bed for a long period of time. And so that's what we mean in terms of enhanced recovery. So those are all the sort of things going on around a knee replacement or a joint replacement that we use to try and optimize the outcomes of that. And then we get to actually talking about the knee replacement. And so I've got a demonstration here of actually there are broadly speaking, two different sorts of knee replacement. Once we're talking about these modern knee replacements that we've got on the right here. There is the possibility of partial joint replacements where just a small portion of the knee is replaced, rather than a total knee replacement where the entire surface of the shin bone and the thigh bone are replaced. And if you look at the pictures here, these are cartoon pictures rather than actual x-rays. What they show is what conceptually it is like. You are only replacing essentially half the joint rather than replacing both sides or all of the joint. And that goes back to what we were talking about right at the beginning when we were looking at why people end up needing to talk about knee replacements, is that they often wear out just one part of their knee. So the inner part of the knee, or the medial part of the knee as shown here, is the most common part of the knee to wear out. And so what are the potential pros and cons of doing partial or total joint replacements? And that's a really important thing that has fairly recently come to national attention. And I put this slide here, not that I expect you to have read or understood what the National Institute for Clinical Health and Care Excellence is, but this is sort of a non-governmental organisation which looks at how we provide healthcare in this country and looks at the evidence around different medical interventions. And it specifically has looked around musculoskeletal problems and in particular joint replacements. And in 2022, the National Institute for Clinical Healthcare Excellence came out with a statement saying that all patients should be given a choice between partial and total joint replacements, with a caveat in those patients where it's appropriate, i.e. you've just worn out an inner or one part of your knee. Now, why have they said that? There has been lots of evidence around partial and total joint replacements, and this is one of the key sort of papers that came out a few years ago looking at the outcomes of these two treatments for knee arthritis. And this information came from the National Joint Registry, which is a British database where we collect information around patients undergoing joint replacements. And that's been collected for nearly 20 years now and has several million patients on it from all sorts of joint replacements. And they were able to look at the outcomes of about 100,000 people who'd undergone partial and total joint replacements. And importantly, what they found is that patients having partial joint replacements actually had shorter lengths of stay in hospital. They had lower complications related to the anaesthetic, lower complications relating to heart attacks and strokes associated with the surgery and the operation. They had lower rates of blood clots in the legs. And when they looked at all of these things, they actually found patients undergoing part knee replacements were less likely to have major complications such as dying as a result of major surgery than having full knee replacements. So the balance was that actually partial joint replacements are probably a bit safer than doing full knee replacements. Now, it's only subtly different, but in the course of hundreds of thousands of people undergoing knee replacements, these are really important things that we need to consider. There are also some other evidence that's come out suggesting that partial knee replacements function a bit more like your normal knee. So they're perceived a bit more like a normal knee rather than a full knee replacement, which feels like a knee replacement, a knee that's been replaced and doesn't feel quite as natural as a normal knee. And there are some slightly improved functional advantages to a partial knee replacement. So again, when we look at how patients get on after their surgery, we find that partial knee replacements have the potential to do slightly better and get back to slightly more activity than those patients undergoing a total knee replacement. So all in all, a partial knee replacement offers lots of advantages. Are there drawbacks? And that's the important conversation that we have with lots of patients around partial joint replacements. And so what we can see when we look at the National Joint Registry, and this is what the National Joint Registry information gives us, is it gives us lots of data about how the joint replacements do. And what we can see is those patients having partial joint replacements are ever so slightly more likely to need redo surgery in the longer term. And we're talking, the data here is at 15 years. And the rates of redo joint replacement surgery are still around 8 to 10%. So they are still low, and that's at 15 years. But they are slightly higher for a partial joint replacement over a total knee replacement. And so when being counselled and when having a conversation with your surgeon around what sort of joint replacements, your suitability for a partial knee replacement needs to be determined, and then an informed decision around the risks, i.e. increased risk of redo joint replacements, against the potential benefits of lower risks of complications, of prolonged stays in hospital, are balanced up against each other. And this is very much an individualised decision that we make with each patient based on this information that I'm presenting you today. So I'll take you back to this picture here, and this is where we started. So most of what we see around the design of knee replacements hasn't fundamentally changed in some time. Some of the materials, the bearing surfaces have moved on, but what I said earlier on is some of the techniques around how we put knee replacements in has developed over time, and in particular with the changes to both computer-assisted navigation and robotic navigation offer some potential advantages. And so to give you a bit of an idea of how knee replacements are done, this is some of the equipment we still use around knee replacements, and they are called instrumented knee replacements. So we use mechanical tools to understand where the bones are and how to be able to accurately resect and remove the worn out pieces of bone in order to be able to replace them with metal and plastic. And this is the technique that was established in the 60s and has remained true, and again remains the gold standard of how we do knee replacements today. But what we are looking at now is actually some slightly different technologies in terms of robotics. And if we think about how life's moved on, robotics and computers have evolved into all parts of our lives. We no longer use dial-up telephones. We no longer use, sort of technologies from the 1960s and 70s, and we've moved to more computers and robotics as to how we do it. But with healthcare, we want to know, does this work? And so this is still something that is being studied at the moment and looked at, but we do believe it offers lots of advantages. In particular, some of the advantages relate to how accurately you can put knee replacements in, and therefore more accurately being able to reproduce a patient's normal anatomy to better produce a normal function of a knee replacement afterwards. And so this is the robotic system we use here at the Horder Centre. It's made by a company who make the implants, a company called Zimmer Biomet, which is a worldwide, well-established company producing this ROSA robot, which works for knee replacements, but also for other joint replacements as well. And to give you an idea of what it does, in theatre, instead of using those manual instruments which are calipered and jigged to be able to understand your knee replacement, we can use the process of the robot to understand where the joints are. And that is a process of manually identifying the knee to the robot. So we demonstrate the anatomy to the robot, which then can sense where everything is. Once it understands where everything is, we can then make accurate decisions as to how the knee replacement is placed, allowing us to respect those soft tissues around the knee and restore that normal anatomy. And actually, we can get some real-time live data about what the intended procedure is going to create in terms of an outcome, i.e. how much the knee will move, how much laxity there will be in the knee, how much movement of the kneecap there is. And all of that can be accurately planned to deliver that output at the end. And so those are the potential advantages. And what that does is it allows us to essentially create a more personalised knee replacement rather than one that is calipered and we try and make that fit everybody irrespective of their anatomy. And that's an important concept that we've come to today, where this is a cartoon or a graphical representation of how people's legs are aligned. So if we look down the middle column here, some people have very straight legs. Some people naturally are a little bit bowed. Some people are naturally a little bit bowed in the opposite direction. But importantly, understanding a patient's normal anatomy allows us to accurately balance the ligaments around the knee to restore the normal and native movements of that knee in its healthy state, rather than trying to make every knee plumb straight, irrespective of the ligaments around it, which can, as we saw earlier on, lead to these potential conflicts and problems with earlier failure, with pain, with abnormal function. And so some of the potential advantages of being able to accurately measure this and accurately deliver this in surgery allow us to personalise patients' knee replacements. And these are just some other conceptual thoughts around knee replacements that, although it may seem like your knee is a hinge, as was thought when that first knee replacement I demonstrated, it's actually a much more complicated joint that not only bends in one plane, but it also rotates and has a degree of laxity side to side that is constrained and controlled by those ligaments which need to be respected throughout. And so it seems like a very sensible thing to think about robotics, but we approach things in a much more moderate way with medicine. And these undergo clinical evaluation and trials. And this is the national study that's actually recently just closed, and we're waiting for the outcomes of it to see, is this a cost-effective and clinically effective tool in the longer term? The safety data is all there. It's all a very, safe and reliable thing. But does this provide us with longer-term benefits that patients experience? The thoughts are, yes, it will, but we want to see what the evidence shows to reliably be able to say that. And so either way, it's important to understand what the expectations around joint replacement surgery are. So in terms of thinking about the recovery from a knee replacement, the recovery is measured in days, weeks and months. And you can think about it in that phase stage. Your initial days in hospital are normally measured in one night or possibly 2 nights in hospital. And in that time, the focus is around management of the swelling, management of the pain, and learning to walk with walking aids. and you are able to go home after 1 or 2 days using some walking aids, but safely able to walk, safely able to go up and down stairs, and safely able to be at home. But that period of recovery is slow and takes a bit of time to recover from the pain and swelling. After the first couple of weeks, that has largely subsided, and the focus then moves to rehabilitation and regaining independence, regaining the movement in the knee, and the reduction in the use of those walking aids. And normally over that 3 to 6 week period, patients are returning to walking increased distances, returning to driving at approximately 6 weeks in patients having had a right knee replacement. If you've got an automatic car and your left knee's done, that can be a lot sooner. And normally by about the 3-month point, patients are about 90% of the way there, i.e. they still remember they've had a knee replacement, they still may have a little ache and a pain, but they've had significant improvements in their functional outcome. But it can take up to 18 months to forget about a knee, and that's an important concept, that you want to live your life not thinking you've had a joint replacement and to have a forgotten joint, and that's the real aim of that. We've talked about how it's done, the outcomes and the recovery. It's important to say that it is a major operation, and therefore the counselling process when considering joint replacement has to involve a discussion around some of the risks of it and the complications. And importantly, thankfully, all of these are really quite rare, but if they do occur, they all can be quite serious. And therefore, there are lots of things that go into the process to try and reduce all of these risks, specifically infection. We've talked about some of the processes that go in before you come into hospital, but certainly in the operating theatre and the sterile environment, all of that is focused around reducing the risk of infection. And the risk of infections in knee replacements, certainly deep infections involving the actual implant itself, are less than 1%. Blood clots is another important consideration, and we actively give you medication to try and treat or to prevent you getting that, and that's blood thinners for a period of about 2 weeks afterwards. In addition, though, that process of early moving around helps get the blood flowing and helps reduce that risk of blood clots. I spent a lot of time talking about pain and how we manage pain, but certainly pain in the early post-operative period can be difficult. There are lots of technical things we've talked about, and that process of accurately recreating your normal anatomy to avoid wear and loosening in the longer term and avoid injury to nerves, blood vessels and tendons in the immediate period around the operation. But say the injury to major structures around the joints, such as ligaments, nerves and blood vessels, again, is vanishingly rare, thankfully way under 1%. Wear, so knee replacements, as with any sort of joint replacements, unfortunately can wear over time. And as we've incrementally gone through those knee replacements, that risk has got less and less and less. And what we see now is actually joint replacements do have longevity, and the National Joint Registry gives us that information. And then there are the medical and the anaesthetic risks that we reviewed, and those are optimised before you go into surgery to again reduce your risk of complications after the surgery. And so what should you expect if you go through a knee replacement? The intention is that it's pain-free. It moves, so i.e. it goes out fully straight and it bends to facilitate you walking around and doing your normal day-to-day activity. And I've put here alignment, so that development of that increased bowing in the leg because of the wear would be corrected. So it would take you back to a normal, healthy alignment, whether that be ever so subtly bowed in one direction or another, but certainly a very normal and healthy alignment. What it may not allow, and what often patients do ask about, is the ability to kneel afterwards. So it's totally safe to kneel. You can kneel on a knee replacement, but it feels generally uncomfortable or unusual to patients. And that's generally because the scar that runs down the anterior aspect of the knee is numb, and patients don't like kneeling on it. People get around that by using pads. So if you're gardening, for example, using knee pads allows patients to kneel on it safely and removes that sensation of feeling uncomfortable. And we've talked about the challenge of trying to get the knee to feel normal and natural. And I mentioned that partial knee replacements patients perceive as feeling more natural. And some of the advantages around how we implant knee replacements may provide us with, in the longer term, a knee that feels much more like a normal knee. But patients with knee replacements often say they feel good. They feel pain-free, but they don't feel quite like their knee before it had arthritis. And knee replacements may not allow you to return to high impact activity. So the expectation around joint replacements are that you should be active, you should be up, you should be walking around. You can return to doing light sports, but I wouldn't suggest that the expectation you could run marathons or half marathons or 10k runs is probably not a reasonable expectation. But the vast majority of patients at the stage where their knee is arthritic are not expecting that. But again, that comes to the counselling around the alternatives, where the expectation, the desire to maintain high impact activity in sports, other treatments may be more appropriate than a knee replacement. And I mentioned, how long do knee replacements last? So this is, again, a really recent publication, because every patient asks, how long does it last? And this is using that information we gained from the National Joint Registry and data from other studies that have occurred over time. And what we can see with knee replacements is at about 25 years, 80% of them are still in there going strong. So they haven't worn out, they haven't failed, they haven't needed redo operations. And at the time when most patients are going through knee replacement surgery, 25 years longevity of that knee replacement is generally more than enough to last a lifetime. So I think in summary, the key things to say are, irrespective of the types of knee replacement that you have, the technologies that you use, the intervention that they're going in, the process has now become one that is thoroughly safe and thoroughly effective. And the enhanced recoveries around it help optimize your outcome, irrespective of the type of surgery you have. Importantly, the preparation for surgery and the rehabilitation processes after the surgery are crucial to getting a satisfactory outcome. We've talked a bit about technology, and we've talked a bit about implants. There has been some incremental improvements over time, but they are incremental, and we constantly strive to be better. But where we are now with the gold standard treatment, it is a good operation that does function well. And I've talked about the importance of discussing options and alternative treatments, particularly around the expectations of knee replacements and how relevant that is to you as an individual. So, well, thank you very much for listening. Apologies, a bit of a crook in my throat. Probably good timing there.
Thank you very much, Mr. Buckle, for your informative presentation and overview of knee replacements. Plenty of information to digest, which I can see has already triggered some questions into the Q&A box. So thank you to those who've already submitted those so far. If you haven't had a chance yet, feel free to type the questions into the box, and we'll do our best to address them in the time that we have left, which is about roughly 12 minutes. So we'll try and get through a few of those, but the first one being, just wondering if there are greater complications or delays in improvement after knee replacement surgery in people with pre-existing conditions like Parkinson's disease.
Yes, that's a very good question. And in terms of the importance of optimizing medical conditions beforehand is really relevant. So we've talked about diabetes, talked about heart disease, talked about respiratory disease, and those are all things that your GP is actively trying to optimize and keep you as healthy as you can be. And we certainly look at before surgery to make sure that's as good as they can be. Parkinson's is really important because people can live well with Parkinson's because of the medications they're on, and that can give them really good disease control. It's so important those medications continue throughout the course of your treatment and admission to hospital. And we're really well aware of how quickly patients can functionally deteriorate if those medications are even missed for one dose. And so we actively manage that throughout your stay to try and keep the Parkinson's as well controlled as possible. And provided your baseline levels of disease control with Parkinson's are good, then your functional expectations and recovery can be pretty close to those of patients without Parkinson's. But clearly, Parkinson's disease, for those people who don't know, has some effects on your motor function, your ability to walk, your risk of falling over, and and that can have an effect on your recovery following surgery, and therefore may make the process a little bit slower. But I think as a sort of positive view on it, the disease control with Parkinson's medications tends to be very good nowadays, and with that maintained throughout the process of joint replacement surgery, the outcomes are still good.
Fantastic. Thank you. Moving on to our second one. So you've got awaiting knee surgery. What are the after surgery restrictions? Will I eventually be able to kneel, get into the loft?
Yeah, so again, try to address that in terms of kneeling. I say to patients, yes, you can kneel. It may feel unusual, it may feel uncomfortable. You may choose to use knee pads. And so this is particularly relevant to lots of people, particularly who enjoy gardening. But those professionals who are still working, so say, for example, you're a carpenter, that's a plumber, somebody who does a manual work that does involve getting down on your knees, it's a really important consideration when we're talking about treatments, particularly joint replacements, but any surgery with scarring on the front of the knee and the uncomfortable sensation you can get after surgery and kneeling on it. So it's a safe thing to kneel afterwards. You may have to modify activity or use knee pads, but certainly it's something that as an individual you should talk with a surgeon about.
Absolutely. Interesting question here of what happens to the cruciate ligaments?
So traditionally, the cruciate ligaments are partly resected. So with all the knee replacement designs, where are we? The cruciate ligaments sit in the middle of the knee. So the cruciate ligaments are two big ligaments that sit in the middle of the knee. One of them, your anterior cruciate ligament, is resected, and that allows the technical bits of the procedure to occur. So in order to be able to move the joint, that is resected. But the implant itself recreates that function. So some of the technical aspects of how the bearing surface is congruent with the metal surface recreates that function. There are types of knee replacement where both your cruciates are completely removed and that function is taken over by the implant itself. And the outcomes of those are comparable to each other. And some of that is surgeon preference as to the type of knee replacement they do and the need to resect those ligaments. So the cruciates actually are less relevant compared to some of the other ligaments. So you've got really important ones down the side of your knee. They're called your collaterals. They're essentially guy ropes that run down the inside and the outside of your knee, and they are absolutely vital to be maintained with any sort of a knee replacement. And they are the key things that we work to try and retension, to rebalance the knee, to take it back to its normal alignment so those pair of ligaments function normally. So yes, cruciate ligaments do get resected, either in their entirety or the whole, but that function is replaced by the implant, but the other ones are much more important.
Great, thank you. We have a question here that says, what type of replacement/surgery is suitable for tricompartmental arthritis in the knee combined with dysplastic trochlea?
Yeah.
Apologies if I've
It's all right.
mispronounced
So
any of those.
to break that down, it goes back to what we were talking about, how your knee can wear out in part or throughout the knee. And I have simplified it a little bit in terms of talking about two halves of the knee, so an inner half and an outer half. But the idea, there are three compartments, three parts of the knee, or tricompartmental is what the question referred to, actually talks about the knee cap as another component to that. And that certainly is a consideration around knee replacements, where some people, the arthritis affects the joint between the shin bone and the thigh bone and here, but actually doesn't affect the knee cap. And so it is possible to do a total knee replacement where the joint surfaces are replaced, but actually leave your own kneecap. And that offers some advantages. And again, is a very normal way of treating it. But if you've got arthritis that affects the kneecap itself is also resurfaced like the thigh bone and the shin bone are. And that's what a knee replacement and patella resurfacing are. A total knee replacement doesn't always include the patella. And again, that's an important consideration that your surgeon will talk to you about the relative pros and cons, your degree of arthritis there, and your symptoms relating to that, and whether it is necessary to replace the patella. And the last bit of the question was about dysplastic. That means a misshapen kneecap. In those sorts of patients where the kneecap is misshapen, they have developed arthritis in that area, then it is generally expected that you should replace all three parts of the knee, the kneecap, the thigh bone and the shin bone.
Great, thank you. As you say, very important to discuss those during your consultation with the surgeon. So another one we have here, how effective are partial or uncompartmental replacements, such as the conformist type for the lateral compartment?
So partial joint replacements, again, I perform lots of partial knee replacements, and there are those advantages that we did talk about. So specifically functional outcomes around partial knee replacements, lower risks of surgery. But the most important thing is the counselling around risks of redo surgery later on. Now, in my opinion, those risks are suitably low enough that it is reasonable to go ahead with partial joint replacements in the right patients. But again, it's an informed consent process. It's important to understand patients' perceptions on risk, and some patients may not want the risk of redo or want to lower the risk of redo joint replacements. And so again, an individual discussion around the relevance of partial joint replacements and total joint replacements is what is suggested both on a national level but also on an individual and personal level. I do think it's a really important topic to discuss with patients. A conformist knee replacement, I personally don't use them, but that is it's a technological change. So it's similar to robotics. It's sort of the step back from that. It is using scans of the knee to plan a knee replacement and provide a personalized knee replacement for that. So we use slightly different technology, which is this sort of next generation on from that, where it's using robotics to understand not just the bones, because scans are really good at doing bones. What they don't do is tell us about tension of ligaments and their function of ligaments, which you can get with the robotics.
Fantastic. Specific question here in terms of getting back to certain hobbies and exercises. Will I be able to get back to horse riding afterwards?
Yeah, so again, that's a reasonable expectation to do after your surgery. In terms of timing of that, normally at the 6-week point, you're free of crutches, you're walking around. You may be able to get back on a horse, but not doing extended periods of riding, certainly taking a very gentle approach to it at that stage. And the 3-month point is probably a more realistic point where you could think about getting back riding too. But no, a knee replacement should allow you sufficient pain relief to get back doing it, should allow you sufficient movement in the knee to get back doing it, and provide you with sufficient stability and trust within the knee to do those things.
Absolutely. It's always good to have expectations of your recovery timeline. So what exercises do you recommend pre and post-op? Obviously, I know you said that there's plenty of sort of patient information, but just perhaps a couple to touch on.
I suppose if you think about it in two ways, your overall cardiovascular health, your ability to exercise is really important, because going through an operation is a physiological stress on the body. We talk about it as a major procedure, and joint replacements are major operations. That's because your body is put under stress by the process of doing the operation and the anaesthetic. And so having good, or as good as it can be, heart and lungs and cardiovascular function is really important, and that can be improved through exercise. So that doesn't have to be specific exercise, that can be making sure you're out, you're walking for extended periods of time. But that's difficult sometimes with painful joints, and so other alternatives such as swimming or cycling can be things that patients with painful joints gravitate towards, and that can help keep the heart and lungs as healthy as they can be, even if their joints are painful. And then there's the element of trying to keep the joint as supple as possible and keep the strength within the joints as well. So the physiotherapy exercises they talk about are all largely involved around trying to maintain the movement, whether that's manually helping the knee move or getting the muscles built up. And the big important muscles are the ones on the front of your thigh, your quadriceps. Those are the most important ones that you use for walking around all the time and need to be strong to recover from surgery.
Fantastic. Just conscious of time, we have a few more, so I will make sure that those remaining questions get addressed in due course. But for now, thank you very much, Mr. Buckle, for providing our expertise this evening, and to everyone who's taken the time to join us. Mr. Buckle is kindly offering 50% off his initial consultation for those who have attended this evening. So if you would like to book a consultation with him, please get in touch via the contacts that are currently on the screen. Actually, sorry, Mr. Buckle, if you just go to the last slide, just to remind people of those details. You will be sent a reference code that will be emailed to you with the webinar recording tomorrow. When you do receive the recording of tonight's webinar, you'll also receive a survey link with just 3 quick questions. It's always helpful to know what's working, but also the areas that we can improve on. So we'd really appreciate hearing from you about how this evening went. But once again, thank you, Mr. Buckle, and thank you to everyone who has logged on tonight, and enjoy the rest of your evening.